Previously on Airway Cops.
He was so anterior.
That's no excuse.
He was obese.
They got something for that.
All he needed was some laryngeal manipulation. Should have been me, not him.
You know that ain't true, Mac.
Damn it, Mac! You know how much your little spree just cost the city? I've been on the phone with the mayor for over an hour trying to convince him that you two were actually doing your jobs out there.
Chief, you want my badge? Here's my badge. You want my laryngoscope? Here's my laryngoscope.
What I want is for you to stop lugging around this death wish that you got and start acting like a good airway cop, just for once. Mac, get your ass back in here. I'm not finished with you yet. Francis, get out there and try to talk some sense into him.
Maybe he is a lunatic airway cop. But he's the lunatic airway cop this city needs. And it's not Francis. It's Miller.
Hi, I'm Mark for ACLS Certification Institute, and that would have been a great show if it hadn't been canceled immediately after the trailer. Today's topic, advanced airway management. Now, years ago, I was assisting with an intubation up on the floor, and the doctor looked at me during the intubation, and he put down his sandwich, and he said, "Mark, what's more important? Is it the person holding the football or the person kicking the football?" And I'm sure I just gave him a dumb look in return, and he said, "It's the guy holding the football." Now, the guy kicking the football gets all the glory, but it's the person holding the football that really makes that ball go through the goalpost. And when we're talking about airway management, it's the same thing. Who's holding the football? Who's preparing the gear? In your crash cart, do you have to have exactly 6 number 3 cc syringes in drawer 2 to save somebody's life? Probably not. Should it be there? Absolutely. Should you check it? Of course. Don't have the right blade to match the handle in an airway kit, and things will go south real quick. So if there's one piece of equipment you have got to check in the morning, whether it's in your ambulance or your crash cart, that's your airway supplies, and that's part of holding the football. Now, if you're a paramedic in the back of an ambulance, most all the other paramedics intubate. That's what paramedics do. We're trained in intubation. If you're a nurse in the ER, you may not necessarily intubate. So your job is really holding the football and preparing it for whoever's going to be doing that airway management, whoever's going to be intubating. And that is critical, making sure that gear is checked and everything's ready to go prior to intubating that patient. So, let's start at the beginning, the endotracheal tube. Notice it comes in a package to keep it clean and protected before it goes in the patient. When you're checking the tube, keep it in the package. You don't have to take it out and start whipping it around like Zorro, getting it all contaminated. Keep it in the package. Open up the cuff or the end that's going to attach to the AMBU bag. Leave the cuff in, the part that's going into the patient. Leave that clean for now. Keep that protected. And I can get to all the parts I need to check it. I have my pilot tube here, so I can check my cuff. Take my 10 cc syringe, inflate the cuff. Check that. Check the integrity. Good. And as I'm feeling here, keep your hand on the pilot tube. You should feel the air go back and forth. That's how you know you have good integrity. And deflate my cuff. Next, I can put in my stylet. Now, when putting in a stylet, just remember not to extend the tip of the stylet past the end of the endotracheal tube. Most intubations that you're going to do in an ambulance or in the ER are crash intubations. Have a stylet in there, especially in the back of an ambulance, because if you need it, you have it. If you don't have it and you're flopping around in the back of the airway, it's too late. You got to stop, then put a stylet in. So I always like to have a stylet in before I intubate. Measure it. Make sure the end doesn't go past the end of the endotracheal tube. You can do this in the package. Then kink off the end so it stays in place. Now, when I'm inserting my tube, I like a little lubricant on it. It slides in a little easier. It doesn't get hung up on the back of the airway. So I might take it out, put a little bit of Surgi lube on the end, just on the tip, and then it goes right back into the package. And this is where it stays until it goes into the patient. So let's take a look at the laryngoscope. This is the primary tool we use for advanced airway management for placing the endotracheal tube in the patient. Make sure you check your equipment before you use it. Make sure that the bulb, when locked in, is activated and bright. You need to have a good view at the back of that airway, so you're going to need a bright light so you can visualize the vocal cords to place that endotracheal tube. A couple of different kind of blades we use. This is a Macintosh blade, a curved blade. And I remember the Macintosh because if you look at it from the side, it kind of looks like the side of an apple. That's a Macintosh blade. Probably the most preferred, most used blade. Now this blade, when inserted into the airway, is designed to go into the vallecula, which is the space above the epiglottis, lifting straight up, and we lift the epiglottis upward, exposing the vocal cord so we can put the tube in. So it doesn't go under the epiglottis, it goes on top of it, into that space known as the vallecula, and we lift up. Now a straight blade, or a Miller blade, which I just happen to have in my pocket here, is different. It does not go into the vallecula. The straight blade is inserted into the oral cavity and it goes underneath the epiglottis, and we're directly lifting the epiglottis out of the way so we can view the vocal cords and insert the endotracheal tube. So, if you're assisting with the intubation, if they ask for a Mac, they're looking for that curved blade. They might say Miller, they're looking for that straight blade. Most folks, in my experience, are Macintosh users. However, there may be certain circumstances where a Mac blade's not going to work. And if it doesn't work, be prepared to switch blades. Have several different blades and several different sizes available before you start your intubation. Let's talk for a minute about maintaining and assessing that airway after the patient's been intubated. Let's say you finished working an arrest, you got a pulse back, you do a 12 lead, and we're going to the cath lab. So we're wheeling down to the cath lab, and on the way, the patient begins to become harder to bag. They're getting harder to bag, their sats are dropping, something's wrong. Remember the acronym DOPE, D-O-P-E. D, displaced tube. Your endotracheal tube popped out. I cannot emphasize enough the importance of securing that endotracheal tube. Now, the AHA for a while was on a big kick on using commercially prepared devices for holding and maintaining the endotracheal tube in place. My experience, a good respiratory therapist, an experienced respiratory therapist, and a good taping job, beautiful. I've had tubes you could swing from trees on this thing. That tube's not moving. However, a lot of the commercially prepared devices also incorporated a bite block, so it would prevent the patient from biting down on the endotracheal tube. Either way, make sure that tube is secure to the patient before you start to move them. Whenever you're moving the patient, say from a bed to a cot, disconnect them off the ventilator. Remove the bag, move the patient over, then reconnect them. This will avoid unnecessary tension on the tube and possibly extubating the patient. Another great method for assessing breath-by-breath status is inline end-tidal CO2 monitoring. This gives you a lifetime, real feedback of this patient's ventilatory status. So if the tube pops out or something goes south, you know it immediately. If I'm transporting a patient on a ventilator, they have end-tidal inline and I'm monitoring it throughout the transport. Oh, obstructed tube. Your patient just threw a lung biscuit into the endotracheal tube. This is where having a Ballard suction is very handy, especially during transport of ventilated patients. This allows you to cleanly Provide suction down the endotracheal tube without contaminating the site. The Ballard suction is in line, it's ready to go the whole time. If I'm doing a vent transport, especially with trach patients, make sure you have a Ballard suction in line on your patient before you start to move. P, pneumothorax. Do they happen? Absolutely. One of the last flights I had in my helicopter, just before we were taking off, the high pressure alarm went off on the ventilator in the ER. I tried to bag him and I got a brick. I can't get air into this patient. We ended up having to do an emergent needle decompression to relieve that tension pneumothorax, which means I had to pull that needle out of my pocket, which means I had to have the needle in my pocket to begin with. If I'm on duty, I have two 14 gauge longs in my pocket ready to go at all times, because pneumothorax happen and they happen at the most inopportune time. Be prepared for that. E, probably one of the most common events is equipment failure. You're bagging the patient, suddenly their sats are starting to drop. You're out of oxygen. Your tank just went dry. Again, check your equipment. Now, Einstein said, what's right is what's left after you've done everything else wrong. What he was really talking about was advanced airway management and have a backup plan. Have a plan B when things go south. Thanks for watching part 1 of Advanced Airway Management. Now in part 2, we're going to cover some of the plan B stuff, some of the options, some of the tools we have in our back pocket to take care of that airway if our first attempt doesn't work. I'm Mark for ACLS Certification Institute, the leader in online ACLS certification.
Previously on Airway Cops.
Did you even have a plan B?
No.
That's what this is for.
Damn it, Mac! Do you know how much your little spree just cost the city? I've been on the phone with the mayor for over an hour trying to convince him that you two were actually doing your jobs out there.
Chief, you want my badge? Here's my badge. You want my laryngoscope? Here's my laryngoscope.
What I want is for you to stop lugging around this death wish that you got and start acting like a good airway cop, just for once. Mac, get your ass back in here. I'm not finished with you yet. Francis, get out there and try to talk some sense into him.
Maybe he is a lunatic airway cop. But he's the lunatic airway cop this city needs. And it's not Francis. It's Miller.
Now remember, in airway management, especially advanced airway management, when we're talking about passing endotracheal tubes and LMAs and King Airways, have a plan B. If the Max blade isn't working, you have a Miller blade standing by. If that isn't working, pull out your King Airway, but have a backup. Have a plan B. After years of tireless research and billions of dollars spent in research and development on new advanced airway techniques, science has finally produced a plastic stick. Yeah. Now, it's a great stick. It's a plastic stick. It's called a bougie, and it's a wonderful instrument. Now, the bougie is one of your plan Bs. A bougie tube, when they're asking for it, it looks like this, comes in a long package. But what this is designed for is when you're intubating and you don't have a great view of the vocal cords, but you got a partial view of the vocal cords, well, you can insert this bougie tube in and get that in that airway, in that little tiny opening through the vocal cords. And then I can feed the endotracheal tube over the top and pass that into the airway. Now, I would have loved to have been there when they were designing this one. Figure like 6 or 7 scientist doctors down in some guy's basement trying to figure out this, and they're going, how am I going to get that big tube in a little airway? It's never going to go. Bob, it's just not going to work. Maybe we should go in through the ear. I don't know. Ted, answer the door. It's the pizza guy. And the pizza guy's watching all this, and finally the pizza guy's like, you know, dude, you could probably just put like a little tube in there and then pass the other tube over the top of it. Wouldn't that work? Get out of here, pizza guy. We're doctors. We're big scientist guys. Get out of here. Go. You, deliver your pizzas. Get out of here. Get. Is he gone? Quick, write that down. What did he say? Put the little tube over the big tube. Now, the bougie tube is designed to be long enough that you can get it in the airway and manage the endotracheal tube into the airway, but not so short that it actually gets sucked down into the airway, which would be a horrible thing. Holy mother of Jefferson Davis, I just lost my bougie tube. So a bougie tube is really something you have to have pretty much ready to go all the time. In fact, you should probably just keep one in your pocket. Wait a minute, they beat you to it. Recently at a conference, I saw they actually make a pocket bougie. Seriously, man, what's next? There you go.
Sir, is there something wrong with your stomach?
No, I'm fine. Another great Plan B option when you just can't get the patient intubated. You're trying, there's fluid in the back of the airway, blood, vomit, schmutz, whatever, you can't get them intubated. Another Plan B option is a supraglottic airway. And all supraglottic means is that the air is being administered to the patient above the glottic opening, so they're not intubated. One of the most popular supraglottic airways on the market today is the King Airway. Now, the King Airway comes in a package just like an endotracheal tube, and it has 2 cuffs on it. One cuff is going to go into the esophagus, and the other cuff is going to inflate in the oral airway. When placing the King Airway, you insert the device blindly, lift up the tongue, and you're going to place it into the esophagus. You're going to go ahead and put your air in through the pilot tube, and this will inflate the distal cuff, which is going to occlude the esophagus. It'll also inflate the proximal cuff, which occludes the oral airway. And when we ventilate, pass air through here, the air goes out these fenestrations, and the only place left it has to go is into the trachea. Because we've blocked off the esophagus, we've blocked off the way out, the air can only go into the trachea. This is a wonderful device. Seen it used with great success many times.
12 o'clock, and time for the headlines of the latest news of the day.
How many times have you heard after the intubation someone complaining that the cords were very anterior? It was a difficult tube, the cords were very anterior. Help your brother, your sister out. If someone's wrestling with an intubation, help them. Especially if the cords are anterior, and we can do that through external laryngeal manipulation. So you see somebody wrestling with the tube, go, hey, I'm going to give you a hand. You reach over, you grab the thyroid and pinch the thyroid. Don't do it this way or put your hands on it. Actually grab it and pinch it. You're going to move it downward and upward and help move those cords more posterior, more into view for the person passing the endotracheal tube. How it'll usually play out is they'll be intubating, and you go, hey, I'm going to help you a little bit. You provide them a little crike pressure downward and upward, and they go, oh, got him right there. You just move the cords into view, hand me the tube, I can put the tube in. Fantastic. Don't let someone wrestle with an intubation. Give them a hand. Now, if you've been doing advanced airway management in the back of an ambulance or in an emergency room for longer than, say, 10 minutes, you've probably encountered the difficulties of intubating the obese patient. You can't watch TV today without seeing something related to obesity in America. Either a diet pill, a diet plan, some piece of exercise equipment, because Americans are becoming obese. and they pose a particular problem for airway management. So now we have this delightful little device called the bell laryngoscope, and a patented procedure for addressing intubating the obese patient. And here's how it works. First, you're going to instrument the airway with your right hand. Yes, the laryngoscope goes in your right hand. First time you picked up a laryngoscope was probably with your right hand if you're right-handed. With your dominant hand, hopefully a little stronger, a little more dexterity. So we're going to put the laryngoscope in your dominant hand. I know what you're thinking. Let me be the first to throw one out there. So, how many Polacks does it take to invent a right-handed laryngoscope? One. That was a lot funnier before. What happened? Herbie, what happened? It went dead. I don't know what happened. It just happened. I was standing right over there when it happened. It went dead. So I'm going to instrument the airway with my right hand. I'm going to reach around with my left hand so I can move the cords into view. Now, they're hard to intubate. I'm lifting a lot of habitus. We've all seen that where the hand's shaking. So the second rescuer is going to reach up, grab that plate, and give me some help. Fantastic. Now I can focus on just keeping those cords in view and pass my endotracheal tube. Bell laryngoscope. When you're looking at intubating the obese patient, have a plan B. If the Mac isn't working, go to a Miller. If the Miller isn't working, pull out a King, but have a backup. Have a plan B for managing that obese airway. I'm Mark for ACLS Certification Institute, and I hope you enjoyed today's lecture on advanced airway management. End-tidal capnography and how we use it in ACLS and especially during a cardiac arrest. Now, what is end-tidal capnography? Well, it's a quantitative measurement of a patient's exhaled CO2, which is the byproduct of cellular metabolism. I kind of think of it like the exhaust in a car. Right? Fill the car up with gas, the motor uses the gas, and then kicks out exhaust. If you get a notice from your admission center like I just got, I'm going to take my van in and have the admission center check my exhaust. And by evaluating the exhaust, they can see if there's a problem with the motor. Well, this is exactly what we're using end-tidal CO2 for in ACLS. Remember, the cells are going to use this oxygen, create this CO2, but I still have to have adequate cardiac output, a working pump, to pump that CO2 all the way back to the lungs so it can be exhaled and measured. Now, usually in the field, I'm using end-tidal to tweak my ventilator. I'm using it for respiratory and pulmonary status. Remember, a normal end-tidal is between 35 and 45. And I could look at those numbers and adjust my ventilator accordingly to keep them within a normal range. However, in ACLS and in a cardiac arrest, I'm using end-tidal not necessarily for the pulmonary or respiratory status, but to look at the function of the pump, the function of the heart. It can also help determine the effectiveness of the chest compressions I'm doing if the heart fails. Now, before we get into these numbers, let's take a quick look at a capnography waveform and define the parts in the waveform. Now, remember, we're talking about the patient's exhaled CO2. So this upward inflection we're seeing here first is the patient exhaling. They're blowing off CO2. So the patient starts to exhale, they're starting to blow off CO2, and we can see this waveform start to rise. Then it plateaus, it levels off, and where it ends and drops is the beginning of the patient's next inspiratory effort. So where are we actually getting this end-tidal number from? Well, it's the end-tidal. Remember that one breath of air, the amount of air that a patient takes in during one breath is called the tidal volume. Whether they take the breath in or we're giving them the breath, that's the tidal volume, the amount of air that's going in during one breath. Now the patient's going to exhale all this tidal volume. And we can see that they're exhaling the tidal volume, exhaling the tidal volume. It ends, they begin to take a breath. So this is their end-tidal exhalation. And that's where we're getting that number from. That's the amount of exhaled CO2 during that one exhaled breath, or exhaled end of tidal volume. Now, moving horizontally from left to right, when we're looking at this waveform, that's a measurement of time. How fast is the patient breathing? Now, to demonstrate this, let's say the patient's respiratory rate goes from 20 to 50. Now you can see how the waveform has become shorter because the patient is taking less time to exhale. So again, moving from left to right, horizontally, that's a measurement of time. We're looking at the patient's respiratory rate, and all this upward deflection is exhalation by the patient. Now, during a cardiac arrest, it's our goal to achieve an end tidal reading of at least 10 or above 10 millimeters of mercury. If during chest compressions you notice that your end tidal reading is at 10 or below, we need to improve the chest compressions we're doing. Another great benefit to continuous end tidal monitoring during a cardiac arrest is to assess for the return of spontaneous circulation. So you're working your full arrest, suddenly your end tidal spikes to over 40. Boom, baby, we have liftoff. Yep, assess your patient. We may have just had a return to spontaneous circulation. Remember, this CO2's been building up in the body, but we've had poor perfusion because we're only providing chest compressions. Suddenly, the heart begins to beat on its own. It rapidly pumps all this CO2 back to the lungs, and we can read that on our end tidal, and that's what caused the rapid increase in our end tidal reading. Now, if your patient has had a return to spontaneous circulation, we're going to adjust our ventilations to achieve an end tidal between 35 and 40. That's our target range we're trying to hit. Another great benefit to continuous end tidal monitoring during an arrest, and especially in the intubated patient, is breath-by-breath monitoring of that ET tube placement. If we're bagging the patient and suddenly our end tidal goes from 30 to 0, reassess the tube. We may have just popped out our endotracheal tube. Remember that pulse oximetry can take 30 seconds up to a minute to adjust. Their saturation may still be fine, but your end tidal waveform is going to drop right off a cliff as soon as that endotracheal tube pops out. So quick review, why do we like end tidal in the full arrest? 1, assessing the quality of our chest compressions. 2, to determine a return of spontaneous circulation in the patient. And 3, breath-by-breath assessment and confirmation of the placement of that endotracheal tube.